Weekend's continuing education event, Ethics in a Pandemic, Lessons Learned from COVID-19. But before we begin, I have a few housekeeping details that I would like to cover with you. I want to cover the information about our continuing education credit. We are offering credit for physicians, nurse practitioners, registered nurses, social workers, and dietitians. Anyone else can receive a certificate of attendance if you would like. Slide 2. We're pleased that none of our presenters or the planning committee have any relevant financial interests to disclose. And the third slide identifies the process that you'll utilize to receive continuing education credit. If you're familiar with our program management system, you can go ahead and enter the activity code 28WISE. If not, we will be putting the information in the chat box, and I will also be emailing it out this weekend to everyone, so you will have a copy of it. By now, many of you are probably Zoom experts, but we're going to do a real quick review of some of its important features that you'll find helpful today. We will be muting everyone except our speakers. We encourage you to leave your camera on. It is much more fun to see faces, especially when you're the speaker. But sometimes you just really don't want to be on camera, and we understand that too. To document your attendance, we really need your name to appear in your square on the screen. If something other than your name is appearing, you can change it easily by putting your computer cursor in the square, and then in the upper right-hand corner of your square, you will see the word More. Just move your cursor to the word More, and a menu of options will pop up, and you can rename yourself. So anytime in the next hour, if you would do that, that would be wonderful. Our speakers will be responding to questions today. And a great way to ask a question or make a comment is to type in the chat box. So I really encourage you to go ahead and open your chat box. If we have time at the end of our presentations, we will unmute the microphones for questions to be asked. And we are recording today's event. Now I will turn the session over to our facilitator, Dr. Bradley Barth.
Thank you very much, Mary Beth. I appreciate it. I'm Brad Barth from Faculty Development, and over the spring and early summer, we held a series of panel discussions to look at and discuss some of the non-clinical impacts that the pandemic was having. Some of the things we looked at were rationing and ethics, the role of public health. We looked at decision-making around the time of the pandemic, looked at technology's role, and then we spent more time kind of digging into the impact on various populations. Some of the populations we discussed were how is it impacting the learners, how is it impacting our faculty, our surgeons, how did it impact the incarcerated populations and isolated or other underrepresented groups. And so over the course of the series, we had a little more than 1,000 participants come for the 13 sessions. And so it was a really great experience. And so I'm delighted to have 3 of the panelists here, 2 so far, and I believe the other one's coming. As Mary Beth said, we'll start with some background information and some questions to the panelists, and then we'll open it up to questions at the end. If you have questions, feel free to put them in the chat as we move along. Our panelists are Dr. Margaret Smith. She is a MD, MPH, and MHSA, and she's an associate professor in the Department of Family Medicine, and she's an assistant dean for diversity and inclusion in the Office of Diversity and Inclusion. Dr. Smith is also a former medical director for Wyandotte County and for Kansas Medicaid, and she's worked as a medical epidemiologist for Kansas and for the university and for the KDHE. Dr. Damian Stevens is an associate professor of medicine in pulmonary and critical care medicine, and he earned his medical degree and completed his residency at UMKC, and he went on to complete his pulmonary and critical care training at Rush University in Chicago, and also earned a Master's of Science in Clinical Research there. He's the program director here at KU for the Sleep Medicine Fellowship and does pulmonary and critical care medicine. Dr. Thurman is also has her MD and MPH, and she's an assistant professor in the Department of Urology, and she specializes in laser prostate surgery. She's also the director of one of our learning societies, the Murphy Society, here in Kansas City. And with that, I'd like to start with Dr. Stevens giving us a little bit of background on what he did and what the early stages of the pandemic looked like for him.
Everyone hear me? Okay, thank you, Dr. Barth, for that introduction, and for also Mary Beth and everyone for inviting me to discuss my experience in New York City again with the group. So where this really started was all the way back in March. It was kind of when things were just starting to pick up in the United States. Even New York was not that busy yet in March. It was still kind of Seattle, a little bit in California. Our new division director, Dr. Castro, got an email from the head of pulmonary critical care there at New York Presbyterian in New York. He's kind of a personal friend, said, hey, you know, we're starting to get in trouble, need help. Is there any chance of volunteers? So, like I said, that conversation started late March. I didn't really talk about volunteering at first because we really didn't know how bad things were going to get here and how quick, but within a week or two, it hadn't changed here much. And then things just completely, you know, got on fire in New York. So then they literally got my privileges, got my state license approval, got everything done within a week. It's kind of funny compared to when I've got licenses in other states, what that typically takes, you know, 3 to 6 months became, you know, 6 to 7 days. And I literally bought my ticket Saturday afternoon and left Sunday morning. I was actually there April the 5th through the 12th. As I kind of referred to, I was at New York Presbyterian. It's a big hospital system there. There's 3 or 4 big hospitals, Montefiore, there's NYU. This is the one that's affiliated with Cornell, and Columbia Presbyterian is the med school there. I was at the Queens campus. Queens is right, many of you probably heard of Elmhurst. That was kind of the ground zero. It was actually worse there. And just to give you a orientation, it's just south of LaGuardia Airport, about 20 minutes. Queens is one of these most multiracial, diverse cities in the United States. Something like it's non-native language is 50% of the households or something like that. And it was kind of an example of what Dr. Barth referred to. A lot of these essential workers, hotel, food industry, a lot of this people, grocery store, vendors out in the street, a lot of them large Hispanic, African-American, Middle Eastern, Asian Indian. You just walking down the street, you'll hear all those languages in any given day. The first couple days, I worked just on the floor doing rapid responses and actually code blues. And there was that many. First day, I went there, got my orientation. Within about 30 minutes, I was already rounding with the team. The next 2 days, I basically helped with running portable ventilators on the floor. There was such a shortage of ICU beds that a patient would go into respiratory failure, require intubation, and they were managed on the floor with a portable ventilator. And then about the last 3 days is the only time I really rounded an ICU team. Literally had, you know, never had a pulmonary critical care fellow, but I did have kind of a shared fellow, a couple of residents, and an intern, a med student at that time. And that was kind of the brief overview of what I did for that week. 7A to 7P every day. The only day I ever left the hotel room to do anything is it's right by Flushing Meadows where they played the Open, and I walked down Saturday evening for an hour, and that was literally the only time I did anything other than work in the hospital. So when I was walking up to this first picture that I think most of you can see now, I was wondering what the trucks were. Those were the refrigerator trucks. Basically every big medical system had a set of trucks out front because all the morgues did not have room for the bodies. You know, even the ones that were going to be cremated had to be stored for some time. And while I'm walking up the street from my hotel, I stayed at a hotel about a mile from the hospital. I saw those trucks, and I kind of made reality hit, kind of hit me when I walked by that and saw that. The second slide is actually a picture of the ICU. And many of you probably heard the term a Pyxis, where you hit the buttons and it opens electronically. This was a floor unit that was converted to ICU, and this is our Pyxis system. As you can see, the emesis basin number 13 was for bed 13, and all the drugs would be put in that box. You'd walk by, there'd be a bag of propofol, a bag of Versed, and this is kind of how you make do in an emergency situation the best you can. The bays in the ER were full of patients in the hallway, so you just kind of did the best that you could do. And the third slide is just a picture of the team that I did finally round with the last few days. This is just a picture of the gear that we put in every day and rounding. And like I said, this was the last 3 days I rounded with the ICU team. They were very appreciative, the entire city. I was walking back from the hospital to the hotel room the last day, and a couple stopped and asked just what was happening and asked where I was from and expressed their gratitude and thankfulness. Every day there would be a local restaurant that would donate food to us. So it was a very grateful city, but at the same time, it was a city in pain.
Thank you. What kind of discussions did they have to have in New York with regard to rationing or?
The main rationing was ICU beds. Like I said, we had ventilators. Granted, they were portable ventilators, and you could argue is that maybe a little less than ideal. And patients would be on the floor, and some would not be on telemetry monitoring. So the quality of the monitoring on the floor, and at the same time, the nursing to patient ratio. I basically, by me being there, I gave, the residents a break, the staff a break, so they would at least be able to take a day off instead of work for, 2 weeks straight. But the other huge shortage was respiratory therapists and nurses. And it was almost a greater shortage of them. They had just set up this kind of recruitment plan right when I was there. And to give you a perspective, the week I was there, it was about the highest death toll the entire week. Basically, some would say the week before I got there, some would say, but most would say even the week I got there was basically the highest positive rate and highest death rate, daily death rate was right when I was there. So that was the main shortage. The as far as other medical intervention was dialysis machines. And when you talk about truly triaging, the closest thing we came to that is every evening before we'd leave at 7 p.m., we would go through the list of patients that had gone into renal failure and was going to have access to CRT, continuous renal replacement therapy. Basically, it's a portable dialysis that instead of being on dialysis intermittently like a patient does at home and comes 3, 4, 6 hours, 3 days a week, this is the continuous machine because their blood pressure is so low, they're so sick, critically ill, they can't maintain their blood pressure with the other form of dialysis. And we only had a handful of machines, and if you went into renal failure and needed dialysis, that had to come with an ICU bed. So every day we would triage who was going to get moved to the ICU in order to get dialysis either that evening or the next day. And that was probably the greatest shortage of any medical intervention we had. Like I said, when I was there, they were talking a lot about the split ventilation. We never really came to that. There was shortage of things. I had to find ABG syringes to do a blood gas myself and those kind of things. So as far as PPE, you would actually use the same mask a couple days. There was a lot of using the same, gown. They would kind of prefer the plastic gowns that had plastic coating over it because we would literally gel the front of the gown. That way we could use the same gown for several patients. There wasn't a lot of this COVID, non-COVID thing because, that was another big question. How do you isolate and avoid cross-infection? Basically, 80% of the hospital was COVID. So there was a couple of units that non-COVID patients were, but there was almost no crossover. I didn't see a single non-COVID patient the entire time I was there.
Thanks. Dr. Thurman, I see you made it. We introduced you earlier, but tell me about what happened with you as a surgeon and the onset of COVID.
Yeah, thanks, Brad. So one day I was really busy, and then the next day we shut it down. So it was a very fast transition from full bore capacity to cancel all elective cases tomorrow. I'm a urologist, and so they highly recommended against seeing clinic patients that were over 65, which is my whole patient population, basically. So I went from being a very busy surgeon to really having to stop. I do BPH, and so in terms of acuity, though I feel my specialty is extremely acute, you know, it's not cancer, it's not an emergency. So it was about a month of very, you know, really looking at ICU capacity, blood supply, PPE, and on major conservation. So we were only taking emergencies to the operating room. And then after about a month, we kind of started getting a little more leeway about what we could operate on. And so there were lots of barriers still, including staffing was difficult. We had decreased the OR staff immensely, so getting back up was difficult. There were lots of different protocols that went through different phases based on recommendations about intubation and how we would decrease the risk of spread of COVID. And so we would intubate and then have a 26-minute period where the room would be completely empty for flow turnover. And so everything just really slowed down.
Yeah. Yeah, thank you. Dr. Smith, I hope I didn't lose you. But when did you start to notice, I guess, what was the first things you noticed in family medicine with the early stages of the pandemic?
So I'm sorry, I'm having technical difficulties. That's why you lost my picture. I had to, in order to be able to manipulate the mute button, I had to close the screen, and then I lost my picture. You lost my picture there.
Right.
So, when the pandemic first started, at least when we first got involved in March, I was actually out of the country, and so I came back to find out that because I'd been out of the country, I had to be quarantined for 14 days before I could go back to seeing patients. And once I came back, we had a very reduced schedule, and most of our patient care was done via telemedicine, so either by the phone or through Zoom visits. I never, once I got back from that initial isolation period, I never actually stopped seeing patients. But for a month or two, it was a very reduced schedule, and then we kind of ramped up again.
Yeah, that's very similar. I think I forgot to mention I'm an emergency physician, and we had a very similar experience as things slowed down pretty dramatically at the first few, kind of tapered down the first few days, first couple of weeks, and then we had a couple of weeks that were really slow, but then things ramped up. Again, back to probably 90% of normal within about 6 weeks of our first patients, I think.
And,
So,
and I would, yeah, I agree with that. And as a family physician, I do both inpatient and outpatient care. And so when I was on the inpatient service, we did take care of the COVID patients who needed to be hospitalized but did not need ICU care.
right. Yeah. What was your experience with rationing care or discussions about rationing it here in Kansas City? I don't know, Dr. Stevens or Dr. Smith or Thurman, any thoughts on that?
There was, I had to say from ICU level, there was not a lot of rationing. The bigger question was how to handle that. Okay, we have 3 separate ICUs on the 6th floor here at KU. Do you intersperse those patients among all units? Do you try to make a dedicated unit with just them? About the closest we came to rationing was there was definitely a shortage of remdesivir when it first got approved. And when that first came out, unless you were one of the centers that was doing the clinical trials, it was difficult to get access to it. That was a pretty short-lived shortage. And now, by and large, that's kind of gone. To a large degree, it was just the medical community trying to, I wouldn't use the word fumbling, but basically just figuring out what's the best way, what's effective, what's not, you know. And even though it had been present, obviously, overseas and on both coasts for quite a while before it even got to Kansas City, we still didn't know exactly the best way to carry it, and we're still learning on that now. You know, you see a lot of mixed data, even about convalescent plasma, steroids. One of the big debates early on was, do we intubate or put these patients on a ventilator, or do we avoid that? And because we were so concerned about transmission and infection, we didn't put them on high flow oxygen. We didn't put them on BiPAP, so we intubated everybody. And in retrospect, there may be some patients that we harmed by doing that, because if we had managed them, quote, non-invasively, meaning, you know, high flow oxygen, but we were more worried about transmission at that time than other things. You know, we basically had almost no medication to begin with, so we were almost of the mindset, if we don't have specific treatment options, let's try to minimize infectious risk to healthcare workers, other people, as much as possible.
Yeah.
I
Go
can.
ahead, Margaret.
I was going to say, I can comment on that. So I think early on, at the health systems level, we had conversations about whether were going to hit a surge and whether we were going to have to ration care, but I don't think we ever hit the numbers that required us to, that overwhelmed our ICU system. What we did do was we had to strategically think about who was going to be in the clinical settings, and because we wanted to make sure we had enough PPE to protect the people who were giving the care, and so as we ramped back up after going to almost completely virtual appointments, what we did in family medicine was have some people come in on certain days and others come in on other days. So we kind of alternated who would be in the clinic, so we could minimize the amount of PPEs that we use. We also dropped back on the number of learners that were integrated into the clinical setting as well.
Right. Right. Yeah, that was a big impact early on, was removing all of the medical students out of the clinical environment, and took some concerted discussions to figure out how to get them back in. I was going to say, you know, along what Damien was saying, in the ED, we really were intubating early, and we're very, very concerned about the risk of spread. And so, like he said, we didn't do any nebulizers or high flow oxygen for risk of spreading or BiPAP. Whereas now we reach for that more quickly, and we also, there was a lot of ingenuity that kind of went along with trying to figure out how do we really minimize the spread of the virus while doing these invasive procedures like intubation or bronchoscopy in the ICU. So, Dr. Thurman, I know we sent a survey around with what the physicians would be willing to flex to and to do. What was the feeling among the surgeons of that, being asked to be a medicine intern again?
Yeah. Well, I'm a fantastic resident, so I was ready to serve. I just need to be told what to do. But many of our surgeons are, trauma surgeons. They run surgical ICUs. So I think a lot of us, felt very comfortable. I haven't intubated anyone in a while, so that was something I was like going to have to practice. But yeah, I was kind of excited to, for that to be a possibility. And I live alone, and so for me, it was like, this is how I can really give back if it's needed, because I'm not putting others at risk and can really isolate very easily.
Yeah. How was it as a surgeon? Surgeons are doers and movers and being asked to sit around and wait. How did your colleagues and you handle that?
Well, it was very painful. I really lost my sense of purpose and had to get creative about how I was going to utilize my time. But once I had a few days to take a breath, it was lovely. And I keep telling myself, we're called human beings, not human doings. So as long as I just kept saying that, like I'm just gonna be, I really wrote a lot of papers. The Journal of Urology submissions went up 25% during quarantine. So people were much more productive academically. I also do the clerkship for urology. So I had medical students, and I, as part of my master's in public health that I got in 2011, I did my dissertation on telemedicine. So I got really creative with how to integrate my students. So all the students that were on urology were, we Zoomed everything. They were in the OR with me. They were in the clinic. They saw telemedicine patients in the clinic through the Zoom platform. And that was really fun. We created in urology a virtual sub-internship. So instead, typically we have a robust program where medical students travel to us. That hasn't been able to happen. So we take 4 students every 2 weeks from across the country. They participate in all clinical activities. So they do clinic with us on iPads, and I have rolly stands and we roll them around. Looks like little ETs and Wallies running around with us. In the operating room, the biotech people in the OR were awesome. They plug directly into the robot. They plug directly into endoscopic equipment. I wear earbuds and I talk to them the whole time I'm doing the operation. We're doing virtual suture labs. We have done didactics. And so we're getting so much excellent feedback on that experience. And so it was just a time to get creative.
Very good. Thank you. Dr. Smith, when did we start seeing the disparate impact on different populations?
So initially, most jurisdictions weren't collecting data on race and ethnicity. But for the places that did, like Michigan and Illinois, we started seeing that pretty early on, end of of March, beginning of April, that the African American and the Latino populations in those states were disproportionately affected by COVID, both in number of cases and in deaths. And so then there was a call to collect race and ethnicity data more widespread. And as we did that we noticed that that trend, while maybe not as prominent as in Michigan and Illinois, has carried through all across the United States. So that about the African American population gets infections probably about 2.5 to 3 times greater than the white population. And it's similar a little in the Latino population.
Yeah. Damien, what were you seeing out in New York among the frontline?
That's definitely what we saw in New York. My difficulty is, like I said, I was in Queens, and although I'd visited a time or two over the last 20 years, I didn't have a good perspective what the population mix was there. In the hospital, yes, it was probably 95% Latino, African, not even African American. There's a large African population, even a lot from Nigeria that are there. So now, although right before I got there, it had hit the Asian population first, because, and that was kind of starting to fade. The week or two before there, I said it was about 50-60% Asian and 30-40% kind of other minority. There's a large Russian population, and there were a few Russians that did. But then within the week, right before I got there, it had kind of switched, and the Asian population was down to 5-10% overall. And then it was Hispanic, probably 30-40%, and African American or African was probably the other 30-40% at that time. Now, when I came back to Kansas City and have been rotated to the ICU a couple different times here, it's probably 90% either. It's actually more even Hispanic population than African American here in the ICU that I've rotated on at KU. But once again, vast majority either Hispanic, African American.
Mm-hmm.
And if you look at the CDC data, even though the rates of infections are about 2.5 to 3 times more in the Latino and the Black African American population, the hospitalization rates are about 5 times more or greater. So people of color are more likely to get hospitalized. And that's probably accounts for what Dr. Stevens was seeing.
Well, and one of our early hotspots here was in nursing homes, and I think we had a really big impact in one of the nursing homes that was predominantly African American.
Right, and if you look at the nursing homes across the nation, those nursing homes that tend to have more people of color, the higher percentage of people of color are more affected by COVID-19 than nursing homes that have a lower Black and Latino population.
Mm-hmm. We also at KU have a pretty large population of incarcerated people from the prisons. And how's that population been affected by COVID?
I can say from an ICU standpoint, we've had at least a guard or 2 and a couple prisoners. Lansing specifically had a large quote outbreak, and I heard numbers. I don't even want to repeat it for the group because I don't know the validity of the numbers, but it was a pretty significant percentage of the total. Like I said, it was guards and prisoners both, but there were very few that got critically ill enough to be transferred. They have an infirmary there, and there was a pretty large number that got transferred to the infirmary. But by and large, most of those individuals did not get critically ill and require transfer here to KU. Some I do know went to Topeka, so it wasn't like necessarily everyone that did get critically ill was transferred here. But as opposed to our, very, concerned group, whenever we heard those numbers, it seems that many of those either got minimally sick or many were asymptomatic. Actually, the vast majority were just entirely asymptomatic.
Now, we normally think of a prison population as kind of an isolated population, but when you think about it, there are people who go in and out of prison, and then the guards obviously go in and out every day. So, but the prison population itself is overcrowded, and there's not a lot of opportunity for social distance. So that population is more likely to get infected. But as Dr. Stevens said, the death rate is probably slightly higher, but not that much higher than the general population.
Good. What other pockets of impact were there that we noticed?
Well, there was certainly the in Kansas, as in other states, the meat processing industry, the people who worked in the meat processing industry were affected by COVID quite a bit. Part of that is because of we think the conditions within those facilities where they have to stand almost shoulder to shoulder working on the assembly lines, and don't get initially didn't have a lot of protective gear, face masks. They're breathing pretty hard because they're trying to work pretty fast, and so it's just a good place to spread the infection.
Yeah. There's a question in the chat about using the prone position. I'd be interested to hear you guys' perspective on that. I did it a few times in the ED with patients that were hovering with SATs in the upper 80s, but were still awake, cooperative, fully mentally there, and would roll them onto their sides or bellies, and it seemed to help. So, but
when I was in New York, that was actually kind of the main intervention at that time. Like I said, there was really no drugs, nothing else. And you would walk into a medical unit, 20, 30, 40 beds, and every single person was proned in that unit. In fact, that was what the orthopedic team became the proning team. Kind of like Dr. Thurman mentioned, a lot of the surgeries, electives were canceled or no such thing. So the orthopedic residents would go from unit to unit and were helping prone patients. And that was kind of the way they pitched in. Everyone did what they could. So the orthopedic surgeon was the proning team. We had kind of different protocols, how many hours were prone. We do that on the ventilator also. So we've done that both non-ventilated and ventilated patients. It definitely will improve oxygen saturations in the vast majority of patients. Is that a prolonged thing, or is it just delaying the progression? We've never really proven that necessarily, but you definitely will see some of those patients, their oxygenation improves when you prone them.
Yeah, good, thank you. So one of the big changes was telemedicine. How has that impacted the three of you? Dr. Thurman, you want to start with that?
Yes, thank you. So I love telemedicine. I think it's fantastic, and I've thought it was fantastic for 10 years. So it was great to be like the surgeon that was like, do this. So for me, I see referrals a lot of time from other urologists. So I already have the data I need about the patient. So it's basically a counseling session. And now I have really incorporated that into my practice, as in new patients that are referred from the outside, oftentimes far away. We do our telemedicine consult. I talk to them about all the options for them. And then we can schedule diagnostic testing or just go straight to the operating room on their next visit. And that has been well received by patients. My oldest telemedicine patient was 90 years old. He was able, with the help of loved ones, to complete the visit via Zoom. So I think telemedicine is fantastic. It definitely saves many of our patients that travel from rural Kansas so much time, money, and energy. So I've been extremely pleased with how it's worked out and want to continue to do it forever.
This is Dr. Smith, and I would second that. As I said early on, we did most of our visits via telemedicine, and I still use it in my daily practice. I have 2 or 3 patients who I see via telemedicine, and then the rest I will see in person. And I feel like this gives my patients who are older, who can't get off work, or who have some other kind of access problem or issue, an opportunity to get in to see me without actually having to take the extra time to drive to the office, to park in our busy parking lot, and then to come to into the building. And so this has been great for our patients. And we can, we've equipped most of our rooms with a televideo, so that our patients can see us, and we can go pretty easily from seeing in person to seeing over Zoom.
I've actually been doing telemedicine here at KU for around 9 years. I've been doing it for a practice in Garden City. So I was very familiar with the whole process to begin with. So that was kind of easier for me probably than a lot of my colleagues that haven't been doing any telemedicine. It's sleep, kind of pulmonary, mainly sleep, but also pulmonary. But yeah, you talk about a lot of people learning Zoom in a fast path. There's a lot of that happening. Patients, like it's already been mentioned, if it avoids a 4-hour, for my patients, some of them, it was a 9-hour trip that they avoided. There's obviously the shortcoming of physical exam, those kind of things. But in reality, the physical examination is probably not quite as important as it was, a generation ago. If you have imaging already, ultrasound, whatever, other things, the hands-on physical exam probably is not as critical. And then if you at least decide that is something that needs to be next, then they do make that trip in the next 2 weeks to see you in clinic. At this point, I'm doing about 1/4 tele and 3/4 in person. But once again, those patients, it's a long trip. The patients like the convenience, even if it's local though, they avoid even a 20-minute trip. And then I have some patients that they spend more time in the parking lot trying to find a parking spot, walking into the building than they do, even driving to KU. So if you avoid all that, it's a benefit. So I think it's one of those things that has always been there. The big thing that remains unknown is the payer reimbursement. Most payer, I've been getting paid for my telemedicine in Garden City for years. Some of the payers were paying, but maybe at a reduced rate, and had some other issues. But I think that's going to be the critical part of this. If that reimbursement is maintained and what the new rules are going to be, there's going to be some pullback. You were getting reimbursed for a phone call. That's probably not going to be occurring going forward. So to some degree, the dust is not settled in my mind until we know what those requirements for it, is it going to be video, is it going to be audio only? The last proposal by Medicare is you can do follow-up visits by tele, but they are not going to probably allow us to bill in person or bill tele for new patients. But once again, that was only proposed. We don't know the absolute final plan yet.
Thank you. Bob and Cheryl Cox in the chat reminds us that Kansas was a big role in this 30 years ago. There was, if I recall correctly, a grant where we really worked on building tight connections with some of the rural hospitals, tight electronic connections so that we could have good quality telemedicine. And Dr. Gary Doolittle was one of our panelists talking about the role of cancer and how he'd been doing telemedicine for so long with doing outreach to rural Kansas. So, and then Damien, there's another question about high flow nasal cannula and improved outcomes compared to intubation. And I think what's your feeling on that?
We definitely know there are some patients that can make it through this with simply high flow oxygen. Like I said, sometimes high flow with combination of proning. Is it sometimes they do heal on their own? Is it the medications we use now? Combination thereof. But yes, we know that a lot of patients can avoid that. You just, once again, have to try to practice protection for the health staff as much as you can to avoid transmission, because it's obviously still that risk, but there is still some risk of that even in patients that were intubated.
Thank you. So what were some of the lessons that we learned or that you learned during this, and how do we move forward? Dr. Smith, you want to start?
Sure. So, as we look at the communities of color and the health disparities and the disparities around the acquiring COVID and dying, I think that one of the big things that I didn't learn, but it really just emphasizes the need to have access to care for everyone. I think that that some of the people who have died have done so because they didn't have access to early testing, because they may not have been able to access primary care, or may have stayed at home when they got sick because they didn't have health insurance. And so I think that really is something that we as a nation need to really think about, and how we're going to protect people. Also, our frontline workers, the people who feed us, who transport us, who do all the things to keep us going. A lot of them were put at risk during this pandemic, and we need to make sure that, again, they are protected. They have the necessary. Early on, I don't think some people didn't even have masks, and they need to have the necessary equipment to protect themselves, and need to be able to have things like time off, so that if they get sick, they can take care of themselves or their loved ones. And so I think we just have to think about how we can take care of the most vulnerable of our population.
Thank you. Dr. Stevens, you want to, or Dr.
I'd say what I'd kind of break it down into is, what did we really learn and what did it reinforce? What Dr. Smith is referring to as what it reinforced. It kind of, something we know in medicine, something the society knows, but it's kind of swept under the rug, or not completely ignored, just not acknowledged. But the effects of socioeconomic and status and health outcomes, and our health system's kind of broken, you know. So as far as what did we learn? Well, we've learned a lot about, you know, COVID-19 and things to try, treatment options. We've learned some things about rationing of medicine, telemedicine, all those things. But like I said, it's a lot of this is things that were there. So it's basically no longer allowing us to ignore it versus new things we've actually learned.
Yeah, there's a question about the meds being used now and PPE and reusing it. You know, so we have, we routinely reuse PPE now. You know, I used to, if I put an N95 mask on or any mask, I would wear it for one patient and throw it away. Whereas now we wear the same general surgical mask all day long. And then, at least in the ED, and then wear an N95 for typically that whole day if I'm wearing one, and then get it. We're using a process of hydrogen peroxide vaporization to clean them out, but there's multiple ways of cleaning and reusing PPE that we do. And then, Damien, I think you mentioned remdesivir and maybe convalescent plasma and Decadron, and what other drugs are we continuing to use?
That's the main things we're actively using. I saw a question even about Plaquenil, hydroxychloroquine. It's probably little role, if any. We are still doing a study looking at healthcare workers to see if there's prevention of transmission for active inpatients. Probably has little, if any, role whatsoever. There's dozens. That's kind of one of the things we've, quote, learned also. When you have something that hits the medical community this hard, this heavy, how do you disseminate knowledge to other, you know, providers? How do you decide what's reasonable? The whole risk-benefit discussion is different if you have no other treatment options and the mortality rate's high enough. So do we set the bar as high as we would for a brand new medication for diabetes when there's already multiple ones on the market? So we've kind of had this whole discussion of, you know, because we know this will happen again. It may not be a coronavirus, it'll be some other virus, but how do we communicate? How do we discuss risk benefit? How do we ration care? All those things. So it's kind of brought that out within the medical community also.
Yeah. Dr. Thurman?
Yes. So one big barrier in the operating room was we were running out of paralytics for anesthesia. So we got really creative with anesthetics. I did spinal anesthesia on a lot of patients that I wouldn't have ever done spinal anesthesia on before, and went well. And we proved to ourselves that we could get creative and remain safe and get the job done. So, you know, lessons learned is flexibility while maintaining safety. And then I think, you know, as a health system and as a country, we kind of learned that you can't make your N95s and your paralytics in China and expect you're going to get those here. I think we learned a lot about, you know, how to create our own force in the country. And quite frankly, I was disappointed in our health system in terms of, you know, the richest country in the world. And it became very evident to me that our health system was all about making money. And that's a personal opinion. And I was just saddened that I have aided in continuing to build that. And I really want to change on a personal level as well.
Yeah. You know, I'm a person who have practiced in the public health world several times in my career, and really the public health was was really key in the pandemic. And I don't think we had consistent messages and throughout the pandemic, and so there was a real failure there. And that's something we need to learn for the next time, that we need to have a consistent message. We need to think about how whatever disease or virus is transmitted, and make sure that we put out the messages so that people can be safe, and people don't get confused and say, should I wear a mask? Shouldn't I wear a mask? It's pretty clear that we can decrease the transmission if we maintain distance and we wash our hands frequently and we wear masks. And that was pretty simple, and yet it got pretty confused, and people saying different things.
Yeah, thank you. I had the good luck to be involved in all 13 of the discussions. And so some of my takeaways for it have been mentioned, but I think that our just-in-time supply chain really puts us at risk. There's a lot of fragility in that. And I hope we've learned a lesson from that. I'm not sure if we have, but I hope we have. And this disease has had horrible impact and has caused a lot of tragedies. But from a science perspective, it's interesting the disparate effects that it has on the body. And though, I mean, I've seen everything from head to toe as the chief complaint from COVID, and so it's gonna keep scientists busy for a long time figuring out how all that happens. And I think my biggest takeaway from all of this is that we are all connected. We like to think that we're our own little island, or that what impacts somebody far, far away doesn't impact me. But it's really clear that things that happen in small markets and across the world, or that happen in the prison down the street, or that happen with my trash collector or bus driver, can all have an impact on me and my family and other patients. So I think it's I hope that is something that we can carry away from it. Is the connectedness of all of us. So that's all I have to say. I really appreciate the help of Drs. Thurman, Stevens, and Smith, and I appreciate you all coming today. Are there any other last points from the panelists or questions from the audience? All right. Well, thank you all so much. Mary Beth, I'll turn it back over to you.
I actually don't have anything to add except enjoy the rest of Alumni Weekend.
Yeah.
Thank you all for coming.
Thank you.
Thank you.
Everyone.
Thank you.